Thank you. It's nice to see our students and our residents and some of my old classmates and some of the clinicians that I work with, and it's a privilege to be on the same podium with the giants in the field. I've been asked to do two things in the next 15 minutes, and that's talk about the OVIVA study and a little bit about interpretation of CNS reports. So we'll try to do both. So OVIVA stands for the oral, it's an acronym, oral versus intravenous antibiotics for bone and joint infections. It's the largest study of its kind to date, and the goal of the study was to determine whether oral antibiotic therapy is non-inferior to IV antibiotic therapy for complex orthopedic infections. And to appreciate where we are, we have to go back to where we were. Now, how many people in the audience recognize this from their child? Probably not a lot. This is Mr. Peabody and Sherman at the Wayback Machine. They're shaking their head yes. So we're going to go back into the 1980s, and specifically we're going to go back to when I graduated in 1983 in the before time. So you know, this is the present time. We have good evidence-based studies on treating bone infections and diabetic foot infections in general, but there was a before time, and I was in the before time. Not quite Mel Gibson, but I remember I grew my mustache to look older, and then later on I shaved my mustache off to look younger. Notice I couldn't get my mustache to go below the level of my lower lip, but it did serve its purpose. So this was 1983. So this was the before time. So what was the before time like? So in the before time, we lived the dogma of 6 weeks of 6 weeks of IV antibiotic therapy as the quote-unquote gold standard for treating diabetic foot osteomyelitis. But the reality is that we were treating, and I mean we and the other clinicians at the time, because I was a new student at that time, we didn't have, not all of us had hospital privileges, and so we were relegated to treating bone infections, usually of the forefoot, with oral antibiotics. And if we wanted to treat with IV antibiotics, if we wanted to adhere to the dogma, then we would have to hook up with another doc who had admitting privileges, or send the patient to the emergency room and they would admit through the ED. And then the patient would probably receive their antibiotic therapy, 6 weeks of IV as inpatients, because at that time, in the before time, the home intravenous antibiotic therapy wasn't as prevalent as it is now. Anybody recognize this? Probably anybody who recognizes the Wayback Machine recognizes where this is from my Mad magazine collection, late to my parents' consternation, my Mad magazine collection. This is from the late 1960s, and it's a dogma, right? So the cross between a dog and Whistler's mother, it's a dogma. But this is a current definition of dogma, and it really points out what dogma is. It's a point of view or tenet put forth as authoritative without authoritative grounds. And the origins of the IV for treating bone infection dogma go way back, and were reinforced by articles such as this by Francis Vollvogel of the Vollvogel classification of osteomyelitis, who wrote in a 1970 article in the New England Journal of Medicine, again, an authoritative journal, so people look at it and listen to it and know who Vollvogel was at the time, and so they pay attention, and you know, driving opinion. Osteomyelitis is rarely controlled without a combination of careful, complete surgical debridement and prolonged 4 to 6 weeks parenteral antibiotic therapy. So talk about influencers today. He was the huge influencer at the time, and he really drove the dogma of IV versus PO. So IV was the way to go, and 6 weeks was the time limit. So Tuesday, February 5th, 2019 at 8:08 a.m., I'm at my desk. And if anybody in here is from the class of 2018, 2019, or 2020, if you were faculty on staff in 2019, this is all pre-pandemic stuff, little did we know what was coming then, right? I had sent to the class and the staff of the foot clinics and NYCPM the newly published OVIVA article. And I said, hi, class. The OVIVA study, IV versus PO antibiotics for OM, it's huge. We've been waiting a long time for this study to finally be completed. So to all the students or whoever that say, well, I've never heard of the OVIVA study, you have if you graduated. You might not open your email, but we gave it to you. So I just want to go over some of the general considerations of the OVIVA study. And this is basically quoting from the study. The trial was deliberately inclusive. There were no selections according to the infecting organism, surgical procedure, or anatomic site. It was the epitome of a take-all-comer study. In this trial, we didn't seek to compare specific antibiotic agents or to stipulate which agent should be used. So at the end of the story, there's no best antibiotic. The trial hypothesis to be proven was appropriately selected oral agents provide adequate antibiotic concentrations at the site of infection. Now, it was a huge study. I would like to say that it was 1,054 diabetic foot infection patients, but it wasn't. It was the epitome of a take-all-comer study. And it was done in the UK. So in England and Scotland, 26 UK centers, 1,054 participants split evenly between the IV and the oral group, and they were randomly assigned to receive either IV or oral antibiotics to complete the first 6 weeks of therapy, with a primary endpoint, and these patients were followed for a year, treatment failure within 1 year after randomization. And again, it wasn't just a foot study. It was, OM from all sources. Native OM of extra-axial skeleton. This is where we come in, right? Including hematogenous and direct extension, right? 98% of the OM that we see is going to be a direct extension. But they also looked at native joint infections, prosthetic joint infections, fixation device infections, spinal infections. So it was a huge range and huge variation. There were diabetic patients in the study. There were 205 diabetic patients in the study. There were foot infection patients in the study. So there was foot osteomyelitis amongst all the other sources. The foot was represented, 175. And other areas of the lower limb, presumably the tibia, fibula, and ankle, right? So there were lower extremity there. But there were other sources as well. And the antibiotic selection, every time I read one of these articles, I said, well, I want to know what they're using at other centers. I want to know what they're using in other countries. I want to know their outcomes so I can use the same antibiotics that they're using to get these results. Well, there was no specific antibiotic regimen that was used. It was basically tailored to the individual patient by the ID doc who was treating that patient. So irregardless of the study, what would you have given that patient anyway? Like, what was the best antibiotic combination? And they chose their antibiotics based upon how you choose your antibiotics. On the CNS, right, the antibiotic susceptibility, the bioavailability of the drug, presumably a highly bioavailable antibiotic versus a lower one, previous infections, contraindications to the drug, allergies, drug interactions, etc. Just what you and I do when we choose an antibiotic. Well, just to get an idea of what was used most frequently, for the IV group, glycopeptides and vancomycin's a glycopeptide. They also use teicoplanin, which is not available in the US. In terms of oral antibiotics, which is what I think everybody is looking at here because we all treat patients as outpatients, quinolones came in number one. Number one quinolone was ciprofloxacin, followed by levofloxacin and moxifloxacin. Tetracyclines, presumably for MRSA, doxycycline, macrolides and lincosamides. I think clarithromycin, although I've never used clarithromycin to treat bone infection. Lincosamides are clindamycin. So we've all, I think, used clindamycin both for soft tissue and bone infections. And then other single antibiotics or combination of antibiotics. So other than what I'm telling you now, I really can't give you any more information on what antibiotics were used in the study. But you do get an idea that in general, this was the study framework. And what about the organisms? Depending upon the site of infection, or maybe not depending upon the site of infection, no matter where the bone infection was, it's pretty much the display of organisms that you and I see in the foot. Staph, strep, coag positive, coag negative, Pseudomonas, gram negatives, right? The best loved organisms. So what are the results? Out of 1,054 participants with endpoint data available for 1,015, again, a huge study to draw some good conclusions. Treatment failure at 1 year. Remember, treatment failure, we want a lower number. So lower number wins. So in a horse race where 14% versus 13%, who do you think came out first? Well, first is sort of the reverse of what you would think, right? So you want a lower treatment failure. So who had the lower treatment failure was the oral group, right? Just by a nose hair crossed that finish line. So essentially a statistical dead heat. The incidence of serious adverse events, pretty much the same in both groups. And as you'd expect in the IV group, the median length of hospital days was shorter. Catheter-related infections, discontinued therapy more often, as you would expect in the IV group. And there was no difference between the oral group or the parenteral group versus C. diff infection. And again, as we said, no significant difference of serious adverse events. So the conclusion, oral antibiotic therapy was non-inferior to IV therapy when used during the first 6 weeks of complex orthopedic infection as assessed by treatment failure at 1 year. And what was also interesting is that when they analyzed the subgroups, they didn't see any significant heterogeneity respective of baseline surgical procedure, the pathogen that was recovered, or the intended antibiotics at randomization. So 2 things I want you to do when you leave here today, and that's look into the details of this study. And it's available online. Go to Google, put in OVIVA and study. And I seem to have better luck getting the full study from the New England Journal of Medicine when I access it on my iPhone versus from my laptop, because then they want you to subscribe or be a member or whatever. So use it on your iPhone, and I've gotten not only the study, but I've gotten the appendices, etc. The other thing I want you to do is to go to a site called bradspellberg.com. And Brad Spellberg is an ID doc from Los Angeles. And he is a friend to podiatry. He's a proponent of oral versus parenteral for diabetic foot osteomyelitis and oral versus parenteral in general. And he has a very excellent site with up-to-date articles. He maintains the site very well. It's a nice way that you can stay up to date in this ever-changing field. So take a look at these studies. So these studies were not, my little thing is working here. So these studies are not just from diabetic foot osteo, but osteomyelitis in general. Look at the numbers of the studies: 30, 50, 26, 30, 39, 40, whoa, 1,054. This is the OVIVA study. So it's not the first, it won't be the last study, but certainly it's the largest study to date. And oral versus IV antibiotics, not only, as we said before, the POET study looking at oral antibiotic therapy for endocarditis, but not only for endocarditis, but other sources as well. So again, trying to break the dogma, be iconoclastic at what we've lived with and practiced with for so long. We're moving in now to the age of evidence-based medicine with excellent studies done by our fellow speakers. The strengths, in my humble opinion, was that it was a huge study. It was 1,054 patients. The weaknesses, not really weaknesses, but things that I would sort of like to have seen. I wanted to know how many patients with OM of the foot had diabetes. I reached out to Ben Lipsky and I said, well, are you going to write a paper or take that data from OVIVA and dissect out the patients with diabetic foot osteomyelitis, and he wasn't able to give me that data, but maybe in the future we can use that data and see, in a more granular way how this applies specifically to diabetic foot osteomyelitis. I'm always interested as to whether there's a best antibiotic. I'm interested to see whether does bioavailability matter. So if I'm treating staph osteomyelitis and I have two drugs that are active against a strain of staph, and let's say one is levofloxacin and one is amoxicillin clavulanate, do I go with the levofloxacin because it has a higher bioavailability, but now I have to risk the side effects that I get with quinolones, or maybe it doesn't matter? So I really want to see more studies on, sort of like which is better, one or two type of thing, which is a better antibiotic. Maybe there are no better antibiotics or best antibiotics. I don't know, but I'm always up for a good study. I thought this was so brilliant. This was an article in Journal of Clinical Medicine published in 2025, co-authored by Dave Armstrong and Eric Seneville. And it's sort of infection from the bacteria standpoint. Now think about this. Bacteria have no mechanism, so I copied this down. I want to read it for you because it's kind of cool. Bacteria have no mechanisms, molecularly or physiologically, to know what route was used to administer antibiotics to a patient. They're like the honey badger, they don't care. Bacteria lack the ability to refuse to stop growing merely because of the antibiotic arrived at the site of infection after passing through the GI tract rather than being injected into the vein. They only know if enough antibiotic arrives at the site of infection to inhibit the growth, and that's true. So, the more studies that we have, the more evidence-based medicine that we pursue, the more we're going to be able to help our patients. I was also asked just to talk a little bit about CNS reports and how to read CNS reports, and I picked, I know we discussed this last year, but there's one point that comes up over and over again. It's like a misconception, and I know we have students here, and we're going to talk about this in class, etc. So I decided to talk about, because I only have 15 minutes, when confronted with two or more antibiotics listed as sensitive, you shouldn't base your choice on which one has the lowest MIC. So constantly docs are saying, well, what antibiotic should I use? I should choose the one with the lowest MIC. If I have two antibiotics to which the organism is sensitive, maybe I should use my choice as to which antibiotic has the lowest MIC. So this is a CNS report from one of the patients who we saw at Met, and as you can see, this is MRSA because it's susceptible, it's resistant to oxacillin, and let's just say it was between linezolid and gentamicin. So I wanted, for whatever reason, those were my two choices, and the reason that I would want to choose one versus the other was the one that had the lowest MICs, which you should not do. Well, you could choose linezolid over gentamicin because gentamicin is nephrotoxic and it's ototoxic. You can choose linezolid over gentamicin because linezolid is in oral and parenteral form and it has a very high bioavailability after oral administration. But you don't choose the gentamicin strictly on the basis of the fact that it has a lower MIC. Choose it on other factors, but don't compare versus the MICs. Let's say linezolid versus vancomycin. Well, linezolid has an MIC of 4, and vanc has an MIC of 2. Well, that should be a red flag. You don't use vancomycin with an MIC of 2 because of MIC creep. And MIC is nephrotoxic, and linezolid is not. So there are reasons why you want to choose one antibiotic over the other, but don't use the MICs. How about rifampin? Rifampin beats them all. Maybe I should just use plain old rifampin as a single agent. But you know that rifampin, when used as a single agent, produces rapid resistance. So again, use your other features of the antibiotics for selection and not the MICs. Remember, the lowest MIC doesn't mean the best drug. The MIC is unique to the antibiotic organism pair. You can't use it to compare one antibiotic from the other. So how do you choose your antibiotic when you have 2 or 3 drugs to which the organism is sensitive? And one of the three principles of antibiotic selection, number three, I think it pertains to us here, once sensitivities are known, choose the narrowest spectrum agent with the best efficacy, the lowest toxicity, and of all things being equal, the lower cost, which brings us back to the slide that we used in the OVIVA study on how they chose the antibiotics for their patient. I'm out of time. I hope this gave you the courage to use oral antibiotics when treating your bone infections. And thank you, everybody, for your time.